Good morning, everyone. First of all, I'd like to thank to Caillou for already inviting me to give a talk in a very wonderful webinar. On this occasion, I'd like to talk about preimplantation genetic diagnosis for hereditary cancer syndrome carrier. Hereditary cancer syndrome actually is a condition resulting from inherited pathogenic variants with elevated cancer risk. Most hereditary cancer syndromes follows autosomal dominance inherited patterns. According to the account, hereditary cancer syndrome contributes to approximately 5 to 10% of all cancer. Individuals with SCS present elevated risk of cancer even at younger age. The cumulative morbidity and mortality associated with hereditary cancer represent a significant burden, underscoring the importance of early detection and preventive studies. Assisted reproductive technology, particularly through preimplantation genetic diagnosis, offer carriers to prevent transmission to their offspring by enabling the selection of embryos. PGD reduces intergenerational propagation of hereditary cancer risk. This approach is especially relevant for SES, with early onset and significant cancer-related morbidity, providing a proactive reproductive option and risk-reducing strategies. Common hereditary cancer syndrome and inheritance patterns. Hereditary breast and ovarian cancer, BRCA1 and autosomal dominant with cancer risk increase the risk of breast, ovarian, prostate, and pancreatic cancer. Lynch syndrome, MLH1, MSH2, MSH6, PMS2, autosomal dominant, high risk of colorectal and endometrial cancer, increase the risk of ovarian, gastric, and urinary tract malignancy. Lee-Fraumeni syndrome, TP53, autosomal dominance, high risk of multiple early onset cancer, including sarcomas, breast cancer, and brain tumor. Familial adenomatous polyposis, autosomal dominant, high risk of colorectal cancer, increased risk of duodenal, thyroid, and desmoid tumor. Multiple endocrine neoplasia, autosomal dominant, high risk of endocrine tumor. Preimplantation genetic testing, PGD or PGTM, is a reproductive option for carriers to prevent the transmission of cancer by exposure mutation to offspring. Patient selection should consider factors including severity of syndrome, age of cancer onset, available strategies, and reproductive goals of couples alongside ethical consideration. Fertility counseling underscores the individualized test counseling for patients. Counseling should include a thorough discuss available reproductive options, psychological aspects, including anxiety and decisional conflict, and ethical consideration surrounding the use of PGD or PGTM. PGT guidelines emphasize that comprehensive genetic counseling and informed consent are essential. Informed consent should ensure that the patient understands the scope and limitation of testing, potential emotional burden, and also financial burden. PGT refers to genetic testing of embryos created through IVF. The primary purpose of PGD or PGT is to identify genetic abnormalities in order to improve reproductive outcomes or to prevent the risk of genetic diseases. Primary purpose of PGTM for prevent the transmission of non-pathogenic variants causing monogenic disorder, including hereditary cancer syndrome. Target of testing specific non-familial gene mutations, indications, carriers at risk of passing the condition to offspring. And PGTA is to improve reproductive outcome by identifying embryos with whole chromosome aneuploidies. Target of testing numerical chromosomal abnormalities with indication to reduce miscarriage rates and improve implantation rate. PGT with the gene detected pathogenic variants in single gene, such as BRCA1 and 2, MLH1, TP53, with impact on inherited disease prevention, directly prevents transmission of inherited monogenic conditions, include ethical debate regarding testing for adult onset and variably penetrant conditions. PGTA with the gain detected gains or losses of entire chromosomes does not prevent transmission of specific inherited single gene disorder, primarily focus on embryo viability rather than disease inheritance. Recent literature adopt the unified term PGT into subcategories, including PGTM for monogenic disorder, PGTA for aneuploidy, and PGTSR for structural rearrangement, replacing all the terminology of PGT. Preimplantation genetic testing for genetic diseases, limits, and review of current literature. This is the biopsy of process. Genetic analysis could be done on polar bodies, plasmid or cleavage stage, and subfactorial cells. PGT biopsy on polar body is less invasive, but only detects maternal genetic mutations. Polar body does not assess paternal gene, limited test for aneuploidy, and lower diagnostic usage. For blastomer, analyze embryo genome directly, enable first transfer, higher risk of mosaicism, impact on embryo viability, limited DNA available. For biopsy traphotoderm, less invasive, best diagnostic accuracy, preserve ICM, more DNA material available, allow multiple analysis, higher embryo survival rate, and required embryo blastocyst on day 5 or on day 6. This is the workflow of preimplantation genetic testing. This is a gold standard, whole biopsy, whole blastocyst, and then this is inner cell mass with the whole genomic amplifications. This is result analysis, true negative, false negative, true positive, and then with false positive. There is a non-invasive of preimplantation genetic testing, based on morphology, morphokinetic, and metabolomic. This is a method for embryo assessment by using span culture embryo or blastole synthesis. This is what we done. Our study on conducted next generation sequencing for non-invasive PGT from culture media and biopsy factor themselves to determine aneuploidy status. We did a study from 240 samples with trophectoderm cells and span blastocyst media. This is, for example, this is the trophectoderm biopsies. This is non-invasive PGT from span culture media. This is full concordance. 46XY. This is partial concordance. This is false negative. And the last is false positive. The average of DNA concentration, embryo with span culture media, 18, embryo with total culture media 25, affected biopsy 30.4. And then the amplification rate of span culture media group was all 100%, with average DNA yield of 18.1 nanogram and 25.2 nanogram per microliter. So I think the result was not identifying PGTA in different cultural media conditions, single culture media, 98% for sensitivity, 80% for specificity, and this is two-step culture media, 85% and 70%. Then this is almost the same between single culture media and two-step culture media. Our study also showed the result of this one is reading of fragment STR, short tandem repeat, the 11 S2362 with S144181 on the sample of cell-free DNA from culture media from the blastocyst of our patient in our clinic. What is the preimplantation genetic testing as a narrative review? According to the S3 PGT Consortium data collection, the most common genetic analysis method used are PGTM, 85% PCR, 8% SNP plus whole genome amplification. PGTSR, 52% FISH, 16% RACDH, and whole genome amplification. PGTA, 35% NDS, plus whole genome amplification, 3% of RACDH, plus whole genome amplification. If you look this one, genetic analysis, method direct multiplex PCR, direct amplification of target DNA region with the advantageous low cost, widely available, contamination risk. There's a contamination risk, amplification bias, allele dropout, and sequence error. FISH. This is the fluorescent molecular probe to identify selected chromosome. Established technique, however limited chromosome analysis. Whole genome amplification. This enables multiple downstream analysis, require maximum coverage of genome and homogeneous amplification. Early CGH, genome-wide aneuploidy detection with high specificity. Cannot detect haploid or polyploid embryos. Balance rearrangement, mosaicism, and single mutation. SNP array, this is genome-wide SNPs and genotyping in single genetic analysis. High resolution, analyze entire DNA sample. Increase analysis time, including 72 hours. 72 hours, costly, limited in consanguinity, not suitable for small structural application. qPCR, fast, only 4 hours, high precision, limited simultaneous sample processing, unable to detect segmental aneuploidy or uniparental lesion. NGS, low simultaneous sample processing, detect aneuploidy, anxiety, copy number variation, and single gene disorder. Cannot detect balance amplification, whole genome amplification related artifacts. Cardio no preclinical outcome. Simultaneous analysis, detect parental haplotype and SNPs, copy number variation. Require familial sample, indirect diagnosis, high cost, unable to detect direct pathogenic variants. Clinical outcome of preimplantation genetic testing for hereditary cancer syndrome. CPR, and live birth rate after PGTM for ACS are similar to outcomes reported for other monogenic disorders. Variability between studies indicates that this rate should not be generalized across all HCS indication or PGTM technique. If you look this table, the clinical pregnancy rate per cycles with embryo transfer following PGTM for hereditary cancer syndrome. Overall, the study is reporting 14 with 195 patients, cycles with embryo transfer 536, confirmed pregnancy 215, with clinical pregnancy rate around 40.1%, with 95 confident interval 36.1 and 44.3. Other HES with clinical pregnancy rate 32.7 and then with the confirmed pregnancy 90. So the weighted mean clinical pregnancy rate was 40.1% per transfer cycle. Clinical pregnancy rate per embryo transfer following PGTM for hereditary cancer syndrome. Overall, the clinical pregnancy rate 35.5%. And then we can see the weighted mean clinical pregnancy rate was 33.5% for embryo. Live birth rate per cycles with embryo transfer following PGTM or hereditary cancer syndromes. The live birth rate around 33.2%. And then the weighted mean live birth rate was 33.2% per transfer cycle. And then the live birth rate embryo transfer following PGTM for hereditary cancer syndrome. Overall live birth rate was 28.9% for embryo. And PGT has been approved for several cancer predisposition genes, including BRCA1, 2, Lynch syndrome, FAP, Lee-Fraumeni syndrome, and MS2. In 2006, approval was expanded for pathogenic variants such as BRCA-related cancer and HNPCC, which are adult onset conditions with incomplete penetrance and available risk reducing treatment. This is a workflow from disease diagnosis to embryo transfer. Provider or counselor, 1 day. Genetic clinics, 60-day. Personalized genetic counseling, 1 day. Pre-PGTM, IVF, 14 days. Biopsy, PGTM, report and post-test counseling, and including up to embryo transfer. The total time between 94 to 123 days, so around 3 to 4 months. What is the challenge and limitation of PGD? Many hereditary cancers are late onset and have low penetrance. This means carrier may never develop the disease. PGT cannot predict age of onset, severity, tumor burden, or future cancer risk. It does not eliminate the risk of other cancer. Access of PGT is limited in some regions due to technical complexity and restricted availability of specialized centers. Technical limitations of PGT include difficulty detecting some pathogenic variants, unavailable haplotype data, and uncertainty about long-term effect of embryo biopsy. What is the ethical and legal boundaries of PGD? HRA and HFEA have accepted PGD for adult onset and low penetrance diseases. However, legal frameworks remain variable in each country. In some cases, the desire for a child outweighs the desire to have children free of that disorder. Concern over embryo's lifespan and disposal. Rates of expanding PGD to non-medical trade raises fears of eugenic and designer baby. Ethical dilemma between reducing future suffering, respecting reproductive autonomy, and avoiding genetic discrimination. And the counseling challenging PGD. Some couples seek PGT without knowing their career status, raising disclosure dilemmas. Comprehensive multidisciplinary counseling is essential to ensure informed decision making. Despite controversies, many couples view PGT as the preferred or only option to avoid hereditary cancer transmission. Other options include indirect testing via grandparents, exclusion testing based on familial haplotype. Intention use intention to use PGD was higher among those planning children, 48% versus 25%. Reproductive age individuals were more supportive to use PGD than those more patient above 40 years old. A teacher taught PGD were not influenced by medical, psychosocial, or social demographic factors. We see the perceived advantages of PGD. Participants did not endorse any of the advantages, avoiding the possibility of pregnancy termination, avoiding the birth another child, reduces chance on miscarriage, then no advantages. Perceived disadvantages of PGD. Participants did not endorse any of these disadvantages, 68%, long-term effect unknown, 18%, low success rate, 10%, chance of wrong diagnosis, 10%, and expensive, 8%. American Society for Reproductive Medicine perspective on PGD or PGTM in HAS. SRM recognizes PGTM, Preimplantation genetic testing for monogenic condition as clinical option for a couple at risk of transmitting pathogenic genetic variants, including those associated with hereditary cancer syndrome, for example, BRCA1 and BRCA2. In the 2023 Practice Committee opinion, SRM outlined that PGTM should be offered when a significant reproductive risk is identified based on validated genetic testing. It's optional, not mandatory. In 2024 Ethics Committee opinion, SRM further stated that PGTM can be ethically justified for adult onset or predisposition condition, such as HES, where condition is often fully penetrant or conferred significant risk. However, counseling and patient autonomy remain central. This table suggested categorization of PGTM indication, category childhood, onset, later or severe conditions like Tay-Sachs disease, sickle cell disease, spinal muscular atrophy, classic cystic fibrosis, serious adult onset condition, hereditary breast and ovarian cancer syndrome, mild condition or indication of limited or questionable risk reduction, is low penetrant or susceptibility gene, mild genetic variants, carrier status, and then the last indication for PGTM is not recommended for autosomal recessive carrier status without manifestation of symptoms. Combination of variants not associated with the disease, within zero deficiency alleles, somatic only variants. What is the extra perspective on PGD or PGTM in SCS? PGT should be technically feasible and offer high diagnostic reliability. Genetic confirmation and family history data, as well as patient selection and risk assessment, must be documented. Counseling, informed consent, and psychological evaluation are recommended as a part of standard practice for PGD or PGTM. Centers should track and follow up pregnancy and outcomes to ensure quality and safety. And this is indication considered acceptable for PGD or PGTM. PGTM is generally considered appropriate when there is a significant genetic risk access. For example, BRCA1, BRCA2, autosomal dominant pathogenic variants, which has 50% chance of transmission. Serious adult onset condition that substantially increase lifetime risk of disease, e.g. adult onset neurodegenerative diseases or cancer. Childhood onset severe genetic conditions, not recommended in carrier status without disease manifestation. For example, simple autosomal recessive carrier without symptoms. Pre and post-test counseling and follow-up. In the pre-test counseling, detailed review of the natural history and penetrance of ACS, explanation of limitation and accuracy of genetic testing and embryo biopsy, discuss of alternative reproductive option, psychological support. Counseling should improve both clinic-based and laboratory-based genetic counselor. With the post-test counseling, PGTM result and discussion of what they mean for embryo transfer decision. Prenatal confirmatory testing should be done for pregnancy after PGD to avoid small risk of misdiagnosis. Long-term tracking of pregnancy outcomes and child health. And the last, I think this is my last slide, the take-home messages. Advances in ART provide carriers an opportunity to prevent transmission of cancer predisposition to the offspring. Comprehensive genetic counseling, patient selection, informed consent, and ethical consideration are fundamental in PGT implementation to ensure that the decision aligns with patient value. PGTM can be over to carrier of hereditary cancer gene mutation as a part of ART when there is a clear pathogenic risk and after thorough evaluation and counseling. SRM and S3 do not mandate PGD but support it as an informed choice with detailed counseling and informed consent at every stage. Follow-up confirmatory testing as well as psychological support are integral part of responsible clinical practice. Thank you so much for your kind attention. Very good morning.